So this is the next in the series of lectures on the peritoneum. Part 1 we had finished last time, and now we'll be talking about part 2, peritoneum. We'll be dealing mainly with peritonitis and subphrenic abscesses. The usual disclosure, this is a non-profit, purely academic presentation, and we have material picked up from a number of sources, including textbooks and the internet. So we'll be talking about peritonitis. Now, the cause, if you look at the cause of peritonitis, the most common, of course, is the bacterial, which could be a gastrointestinal origin or it could be non-gastrointestinal origin. Number two, it could be a chemical peritonitis, like for example, if there has been a leakage of bile or if there has been a perforation of the duodenum. It could be an allergic, usually starch, and this starch is usually from the gloves. Not very common, it's a rare form of peritonitis. Traumatic and post-operative, they both end up with the same result. Either you have a surgical trauma or you have an inadvertent trauma. And along with that, you could be having a drain inside the peritoneal cavity. There could be leaks in the peritoneal cavity from gastroduodenal anastomosis or gastrointestinal anastomosis, or from intestinal anastomosis. There could be secondary infections. There could be perforative, which is perhaps one of the more common forms of peritonitis. It could be ischemic, like for example, if you have a supramesenteric artery syndrome or you have ischemic jejunitis, so there could be vascular occlusion or it could be infective gangrene. Then certain miscellaneous causes, including familial Mediterranean fever and of course dementia. Now, acute bacterial peritonitis. Now, if you look at the definitions, there are a number of definitions which are important, which you will be facing or you come across a number of times, and these are basically pathophysiological definitions. So we have the three types: the primary, the secondary, and the tertiary type of peritonitis. That's one way of looking at it. Primary peritonitis is when we are talking about an infection in the peritoneal cavity without a breach in the peritoneal cavity or a GI tract. That basically means that there has been no direct leakage from the gastrointestinal contents, or there has been no direct introduction of infection into the abdominal cavity through a rent in the parietal peritoneum. So usually, most commonly, this form of peritonitis is seen in those patients who have ascites for any reason. And among the more common causes of ascites, which give rise to a primary peritonitis, is a cirrhotic ascites, or it could be a patient who will be on peritoneal dialysis. And in these instances, the terminology of this primary peritonitis is also known as spontaneous bacterial peritonitis, or SBP. It's usually monomicrobial. In children, the ascites could be nephrogenic origin or it could be a cardiac ascites. The second instance where you can get a primary peritonitis, apart from ascites getting infected, could be a blood-borne infection into the peritoneal cavity. But coming to the most common form of peritonitis, that is the secondary peritonitis, which occurs as a direct spillage of gut organisms through either perforation in the GI, or there could be translocation through an inflamed intra-abdominal organ or damaged viscous wall, which becomes more permeable to the intra-luminal contents, which now go across the wall into the peritoneal cavity. It's always polymicrobial, and most commonly you will be able to identify the gram-negative enterococci. And then you got the tertiary, which is a terminology which is less well, or I would say least well understood. This, we are talking about peritonitis in a critically ill patient or with a poor immune status. And usually the scenario is that there has been an inadequate or incomplete treatment of secondary peritonitis. The infection has not been completely eradicated. And the causative organisms in these cases is either Enterococcus group, the Fecalus or Faecium, or it could be Staphylococcus, it could be fungal also, and of course Pseudomonas. Now, talking about the primary peritonitis, or more specifically, the variety of primary peritonitis, that is spontaneous bacterial peritonitis. Now, what are we talking about? Now, as I said earlier, there is no breach in the peritoneal cavity of the GI tract. Most commonly, it's a second infection in the ascites. So, when does this infection occur in the ascites? In every patient? No, it doesn't. There are a number of high-risk scenarios where you'll be getting this kind of spontaneous bacterial peritonitis. A high risk of spontaneous bacterial peritonitis, or SBP, in patients or in children with nephrosis. We just said nephrogenic ascites. Highest risk in patients with decompensated cirrhosis. A compensated cirrhosis is much less liable to get an infection in the ascites as compared to a patient who has had a decompensative cirrhosis. And similarly, if this patient has got a decreased hepatic synthetic function with low complement levels or prolonged Peritoneum time, he is at maximum risk of this form of peritonitis. In fact, in those patients who have a low protein level in acidic fluid, less than 1 gram percent, there is a 40% incidence or 10 times higher risk of developing this form of spontaneous bacterial peritonitis. Approximately 10 to 30% of patients with cirrhosis and ascites would be developing spontaneous bacterial peritonitis. Less commonly, as I said earlier, the second scenario is hematogenous seeding, and this usually occurs in the presence of bacteremia following upper respiratory tract infection in children or mesenteric lymphadenitis. Now, the pathogenesis of a spontaneous bacterial peritonitis, the mechanism for bacterial inoculation of ascites is debatable. After all, how does the bacteria reach there? It has to be translocation, but remember the wall is not increasingly permeable, nor has there been a breach. So, from the intestinal lumen into the ascites, that is occurring. And how do we know that? Because there is increased isolation of enteric organisms in the acidic fluid in spontaneous bacterial peritonitis. That is clear. So there has been translocation. So why does this occur? Either a hematogenous transmission in combination with an impaired immune system leads to infection in the ascites, or there's intestinal bacterial overgrowth found in these people with cirrhosis, mainly attributable to what? A delayed intestinal transit time in a patient who's got cirrhotic ascites. There's an impaired phagocytic function. There's a low serum and acidic complement levels, and a decreased activity of the reticular endothelial system. Either one of these all together, they all contribute to increased number of microorganisms and decreased capacity to clear them from the bloodstream, resulting in their migration into an eventual proliferation, of course, in the 90%, more than 90% of cases of these spontaneous bacterial peritonitis are caused by monomicrobial. This we stressed even earlier, but needs stressing again. Only less than 10% are polymicrobial. And the most common pathogen would depend upon the age group. In a cirrhotic ascites, in an adult, the aerobic enteric flora, the gram-negative organisms, and to a certain extent gram-positive organisms would be responsible. So you have the predominantly gram-negative organisms like E. coli 40% of the time, Klebsiella, the Pseudomonas, Proteus, and other gram-negative species. But on the other hand, in children, the ascites tends to get infected by a gram-positive organism. Again, it's monomicrobial, but here it is gram-positive as opposed to a patient of cirrhotic ascites who's an adult, whereas gram-negative, here is gram-positive organism, Streptococcus pneumoniae, Streptococcus, other species, and of course Staphylococcus species. And some data has now emerged which suggests that the percentage of gram-positive infections may actually be increasing. Anaerobic organisms, microorganisms, are rare. That is singularly important, and they are found in less than 5% of cases. Probably has to do with the high oxygen volume of the intestinal wall and the surrounding tissue. A word of caution, a word of caution. It's a very important thing, and that is in all patients with spontaneous bacterial peritonitis, or in all patients who have got cirrhosis, ascites, and they're infected, not all of them would be having spontaneous bacterial peritonitis. 15% of these patients who have been labeled as spontaneous bacterial peritonitis may actually be having secondary peritonitis. So you have to be on a guard. Why? Because the pathogenesis is different, the treatment is entirely different when you're talking about a primary peritonitis, which is of the spontaneous bacterial peritonitis type, or we're talking about an actual secondary peritonitis. And that is why the differentiation becomes important and may not be easy. It's not very easy. Why? Because the clinical signs and symptoms alone are not sensitive or specific enough to reliably differentiate between SPD and a secondary peritonitis. You need a thorough history, you need evaluation of the peritoneal fluid, and additional diagnostic tests are needed to do so. A high index suspicion is also required. And that is why a differential diagnosis of secondary peritonitis from a spontaneous bacterial peritonitis is always on the cards, and it's very, very important. Right? The clinical presentation of a spontaneous bacterial peritonitis, it is 30% time you have absolutely no symptoms. Fever, chills may be found in 80% of patients, abdominal pain or discomfort 70% of patients, and other signs symptoms which could immediately alert you to the fact that probably this patient who has got cirrhotic ascites is now getting a spontaneous bacterial peritonitis. Like for example, worsening or unexplained encephalopathy. a diarrhea and vomiting appearing for the first time, ascites that does not improve following administration of diuretic medication, worsening or new onset renal failure, ILS, and variable tachycardia, hypertension, abdominal tenderness, and late features of sepsis and shock are all those which should alert you the possibility of impending SBP or spontaneous bacterial peritonitis. How do you make a diagnosis? The early diagnostic paracentesis, which is defined as a paracentesis done within 11 hours of presentation. That is the definition of an early diagnostic paracentesis. So immediately as the patient you are alerted that probably this patient will be having a SPB, you immediately go in for ascitic diagnostic tab, and what are you looking for? You're looking for the neutrophil count. Anything more than 250 cells per microliter results in an increased sensitivity of 93% but a lower specificity of 94%. So that means the neutrophil count is highly sensitive and specific as a predictor of a possibility of a SBB. Now, more than 500 cells, sensitivity 86, but if you take it as cutoff level 250 cells, the sensitivity increases to 93%. Gram stain, very rarely informative. That is very important to remember. Why? Because the bacterial concentration is never enough to give you a positive gram stain. Culture, even with a raised acidic polymorphonucleoside and clinical symptoms, is positive and possible only in 40%. So the gram stain in cultures are not very good indicators of infection or diagnostic parameters of SBB. On the other hand, high acidic leukocyte esterase, bedside can be done easily bedside, immediately gives you a count even without putting the acidic fluid under the microscope. On a bedside, you can say, yes, this patient got a high leukocyte content in the acidic fluid. Or you can do acidic calprotectin, high level is found, and its level in any body fluid is proportional to the level of neutrophils present in that fluid. You can also go in for blood and urine cultures, rule out secondary peritonitis as stressed earlier. These are all additive for diagnosing infection of SPB. So how do you treat it? So if you have a symptomatic patient or you have a asymptomatic patient, it's as simple as that. So if the count is more than 250 cells per microliter and the patient is asymptomatic, just oral ofloxacin 40 milligrams twice a day suffices, right? But if the patient is symptomatic, that we just not talked about the symptoms in a patient SBP. So what are you looking for? You should immediately initiate treatment with intravenous third generation cephalosporin, preferably cefotoxime, 2 gram every 8 hours, or a combination of amoxiclav or quinolones. That is the standard of treatment. The plasma expansion with albumin improves the survival and reduces the occurrence of hepatorenal syndrome and hospital mortality. So albumin always is additive in the form that it decreases the morbidity and mortality. The prognosis of SBB is immediate mortality is low. That's why this considered to be one of the better forms of peritonitis to have. And death, if it occurs in SBB, is more because of an associated hepatic failure, GI hemorrhage, or hepatorenal syndrome rather than because of septicemia. A cirrhotic with infection, that is SPB, 1 year survival rate is 30% and 2 year survival rate is 20%. Before we go on to the secondary peritonitis, which is a more common form, let's talk in short about tertiary peritonitis. And what is tertiary peritonitis? When we talk about tertiary peritonitis, we are looking at a clinical syndrome that can be defined as a persistent peritoneal infection. And that's why it's also known as persistent peritonitis. And that is usually occurring after apparently adequate therapy. Obviously, it has not been adequate, but apparently it was adequate of either primary or secondary peritonitis. So you have a patient of primary, you have a patient of secondary who has been treated adequately, apparently, but inapparently in reality. So this patient has a residual infection or persistent of peritonitis. A common complication of intra-abdominal infection in patients admitted to an ICU, and that's why tertiary peritonitis is most commonly found in the ICU patient. Characterized by what? Organ dysfunction, prolonged systemic inflammatory response syndrome, recurring peritoneal infection with organisms of low intrinsic pathogenicity are the hallmarks of tertiary peritonitis. What are the risk factors? In which patients should you look for tertiary peritonitis? A patient who is on immune suppression or whose immunity has been depressed already, malnutrition, high acute physiology score, organ system failure, chronic health evaluation score might occur in the presence of microbes that are resistant to therapy. Now, the etiology of tertiary peritonitis, I said earlier, the infective organism most commonly are the enterococci group, the candidiasis, that is fungal, pseudomonas, staphylococcus, and enterobacter. But what are the foci? From where is it coming? Rarely this foci, which was either the initial secondary peritonitis or primary peritonitis, or else it is a low-grade persistent peritonitis by itself. The infective foci is really amenable to percurrence drainage, and it is poorly localized at laparotomy, and that is the problem with tertiary peritonitis. You're not able to localize the offending site, that means the foci from where this infection is persisting or where it's coming from. And that's why you have to differentially diagnose it from uncomplicated secondary peritonitis, and the differentiation depends on its microbial flora, the lack of response to appropriate surgical antibiotic therapy, which is the hallmark of secondary peritonitis, which is easily amenable to appropriate surgical antibiotic therapy, unlike tertiary, which is not. And like nosocomial pneumonia in the critically ill patient, the syndrome appears to be more a reflection than a cause of adverse outcome. So that basically means that the adverse outcome is not because of tertiary peritonitis, but tertiary peritonitis is an indicator of an adverse outcome. And the mortality rates are high, more than 50%. Right? But coming to the most important form of peritonitis, known as secondary bacterial peritonitis, also known as acute bacterial peritonitis, or ABP. Now, if you look at the pathogenesis, the most common etiological entities of acute bacterial peritonitis or secondary peritonitis include perforations. It could be gastric, duodenal, and to go down the line, it could be jejunal, it could be ileal, it could be gallbladder, it could be diverticular disease, and so on and so forth. It could be post-inflammatory, where the porosity or the permeability of the wall of the gut has become more permeable, it has increased, so that the intraluminal organs now can be easily translocated. Like, for example, appendicitis, diverticulitis, a patient acute cholecystitis, sigmoid diverticulitis, ischemic disease, where the wall is so thinned out that the translocation occurs very easily. Or it could be seen after post-obstruction or strangulation, like, for example, volvulus, closed loop obstruction, or there has been a hernia which has now become obstructed. It could also be seen after rupture of a liver abscess. Could be seen in a patient who has got abdominal malignancy. Infected necrotizing pancreatitis, the necrosis of the pancreas has now become infected. Or there could be exogenous contamination, like, for example, you put in a drain and that drain becomes the route through which infection goes into the peritoneal cavity. It could be a penetrating injury, like, for example, a stab injury. Post-operative, you could have a exogenous contamination of the peritoneal cavity. Rarely, it could be an ascending female genital tract infection, or it could be secondary to salpingitis. Salpingitis gonococcal, which is fortunately now very rare. It could be non-specific bacterial or chlamydial. But in females, there's a very special type of ascending female genital tract infection leading to what is known as the Fitzhugh-Curtis syndrome. Now, exclusively, obviously, in female, it's an ascending infection via the female genital tract. The cervical mucus is thinned out so that it allows bacteria from the vagina into the uterus through the cervix, goes into the tubes, and can result in adhesive bands forming around the Glisson's capsule, which is the capsule around the liver, to the parietal peritoneum, and thin layer of connective tissue surrounding the liver. So that is basically what we're looking at when we're talking about the pathogenesis of a secondary bacterial peritonitis, also known as acute bacterial peritonitis. Look at the bacteriology. We were talking about monomicrobial when we were talking about the primary peritonitis, and in tertiary we're talking about low pathogenic organism. Here we're talking about the full-blown infection, which is polymicrobial and would depend upon the site of pathology. So if the proximal GI or upper GI, is probably more commonly gram-positive, with a shift towards gram-negative organism in those patients who have been on prolonged gastric acid suppression therapy. So if you've been having a lot of pantoprazole or other proton pump inhibitors for a long period of time, you would tend to, and then you have perforation, you would tend to have more commonly a gram-negative infection rather than a gram-positive infection. But otherwise, upper GI, gram-positive polymicrobial. Distal small bowel, as you go down the bowel more and more distally, it becomes a mixture of several hundred bacterial species and fungi. The host defenses normally would quickly eliminate, but depending upon the amount of outpouring of the bacteria and the fungus, the peritonitis is almost always polymicrobial, containing a mixture of aerobic, anaerobic, with a predominance of gram-negative organisms. and they all belong to the enterococci, clostridial group, bacteroid, and streptococci. Clostridium obviously is a gram-positive organism we're talking about. So it would be anaerobic, aerobic, and gram-negative. So we are basically talking the whole mixture. But here, remember, if you remember when you talk about primary peritonitis, we said anaerobic organisms are usually not found, less than 5%. But here, anaerobic organisms are in quite a high percentage, right? If you look at the anatomical manifestations of bacterial peritonitis, depending upon the site, it could be diffuse, that means the whole peritoneal cavity is involved. It could be localized, and where does the localization occur? Under the diaphragm, subphrenic. It could be above the transverse colon, that is the supracholic compartment, below infracholic compartment. It could be paracholic, and it could be the pelvic cavity. So these are the localized forms and the diffuse form. Diffuse form, whole peritoneal cavity; localized form, it could be either of the one that we just now enumerated. The anatomical disposition, whether it is going to be diffuse or localized in a particular patient, can be actually be the number of reasons for it. There could be a prediction to that, and it will depend upon number one, age of the patient. Younger age group and older age group, they tend to have more commonly diffuse. Virulence and bacterial load, the more the virulence, the more the bacterial load, more commonly diffuse. Peritoneal fibrin activity, if it is fibrinolysis, then more of diffuse, less fibrinolysis, more fibrin stands, they tend to collect the bacteria at spots, so it would be more of a localized form. Peristaltic activity, remember, the more the peristaltic activity, the more the dissemination of bacteria along the pathways to the whole of the peritoneal cavity. So if the patient has got paralytic ileus, he would tend to have more of a localized. If he has increased peristaltic activity, it will be more of a diffuse. Similarly, greater omentum, which is the policeman of the guard of the abdomen. So if you got a very short omentum, the chances of infection being walled off is less, so it becomes more diffuse. And of course, host defense. So all these factors have got an important role to play. These are variables which are important to ultimately decide whether the patient is going to have a diffuse or a localized form of peritonitis. The clinical features would depend upon whether it's a localized or a diffuse. So in a localized peritonitis, you would be having symptoms of the underlying disease. Like, for example, if it's a localized secondary to acute appendicitis, so you'll be having a localized abscess in the periappendicular area. So depending on the underlying disease. Visceral pain to somatic component. So initially starts the visceral pain, and once gets localized to the parallel peritoneum, forming a localized abscess, becomes a somatic component, right? A typical example again is appendicitis. In the initial stages, where do you have the pain? You have the pain in the epigastrium or periumbilical. Subsequently, going on to the right ileal fossa, when the peritoneum, parietal peritoneum gets inflamed. So, localized rigidity, guarding, rebound tenderness, and of course, systemic signs of infection would be there depending upon the degree of infection. On the other hand, if it's a diffuse peritonitis, diffuse acute bacterial peritonitis, the initial localized pain becomes generalized very soon. The respiration becomes painful. So there's catch in the breath, labored respiration. Why? Because the diaphragm, whenever it descends down, the parietal peritoneum underneath the diaphragm becomes, because it's inflamed, gives pain. So this patient will be having systemic symptoms in the form of increased temperature, you'll be febrile, there are frequent vomitings. Once the infection reaches the pelvic cavity, it will be burning micturition, profuse diarrhea, especially when there's a pelvic collection. There could be abdominal distension, especially because of paralytic ileus. Generalized rigidity and guarding spread all over the abdomen in the initial stages, may become less pronounced as the time passes on, and of course, features of hypovolemic septicemic shock, which is a compound shock. Now, how do you diagnose? Remember we said differentiating between primary and secondary is very important. So how do you diagnose a secondary peritonitis or acute bacterial peritonitis, which is a form of secondary peritonitis? So there has to be increased systemic polymorphonuclear leukocytosis. Number one. Number two, peritoneal fluid analysis characteristically would be the color itself would be showing pus as opposed to clear fluid in a spontaneous bacterial peritonitis of the acidic type, or sticky odorless fluid in a pneumococcal infection. An extremely elevated polymorpholeukocytes in the acidic fluid, also in the serum and the acidic fluid. A high acidic leukocyte esterase, gram stain really helps, as also in a SPB culture. Multiple bacteria, often including fungi, can be identified, and a sensitivity report can easily be had, and at least two of the following criteria. Number one, total peritoneal fluid protein greater than 1 gram per deciliter, lactate dehydrogenase or LDH above the upper limit of normal serum levels, and glucose less than 50 milligram deciliter. Serum amylase, especially in those patients where it's secondary to acute pancreatitis, that means the bacterial peritonitis secondary to acute pancreatitis, blood and urine culture, and serum electrolytes, liver function test, and kidney function test are all essential additives which need to be done in all these patients. Radiologically, can you diagnose a patient of acute bacterial peritonitis? In a plain skygram of the abdomen, AP view in the erect posture. Remember, that's why it's labeled in red. Abdominal X-ray, AP view, erect posture. What are you looking for? Multiple fluid levels. See these fluid levels? So these are the multiple fluid levels. If associated intestinal obstruction or paralytic ileus. Ground glass pelvis because of fluid in the pelvis. Gas under the right dome of diaphragm is characteristic of any kind of perforation, and it has to be differentially diagnosed from other reasons why you can find a similar appearance of gas under the diaphragm. Like for example, a sapropnetic abscess, where the gas-producing organism gives rise to gas under the diaphragm. You can have a Chilaiditi syndrome, which is nothing but a dilated, intersposed transverse colon, gaseous. The transverse colon lies like this and gives an erroneous view of a gas under the diaphragm. You could have a post-operative or post-laparoscopic, post-peritoneal dialysis, post-tubal insufflation, or there could be respiratory causes in the form of linear atelectasis or the base of the lungs. If you have atelectasis out here, it can give an erroneous appearance of gas under the diaphragm. A bronchopleural fistula, non-invasive positive airway pressure when the air is forced both down the trachea and the duodenum, so that can as well give an erroneous view of gas under the diaphragm. Gas in the subhepatic or Morrison spout. And what are we looking at? Look at this figure, the 11th rib. So this is a diagrammatic representation. You got the 11th rib, this is the liver, the upper pole of the kidney, and the adrenal. So this is the Morrison spout that you have. So if you have air trapped out here on a skygram, it would appear as a air which is inferolateral, superomedial to inferolateral, superomedial to inferolateral orientation, not in continuity with the generalized pneumoperitoneum, and lying underneath the 11th rib. So that's the 11th rib, and you can find it lying under this, and it's a triangular gas shadow. See the triangle out here? It's just shaped like a triangular gas shadow. Now, the second thing is that you can get a plain skygram of the abdomen even in a supine position or a lateral view. And what you're looking for, the special signs that you're looking for in an AP view on a supine position would be number one, the regular sign, the cupola sign, which we talk about in the next two slides. The umbilical ligaments, they stand out because all around there's the air in the peritoneal cavity, and you can see this, the black arrow. Can you see this black arrow? So that's the falciform ligament sign, which is the black arrow, and it stands out like a white streak above the surrounding dark gaseous area, right? A football sign is something which resembles an American football, and the seam of this American football is the falciform ligament. See this falciform ligament? So you have air on this side, and the opacity, which is another method of or another manifestation of a falciform ligament sign. And what is important is that the football sign can only be elicited or can be seen in children, in the pediatric patient, but never in an adult patient. Why? Because the amount of gas in the adult abdomen is never enough to give rise to a complete opacity a complete picture of air in the peritoneal cavity, as opposed to a child where the abdominal cavity very easily fills up with air and gives the typical football sign. The football sign, remember, is only to be seen in a pediatric age group, never in the adult. But coming to the two important signs, that the regular or the bas relief sign, which is seen on a supine AP view. And what are we talking about? This is basically seeing both edges of the intestinal wall, the inside and the outside. And this has to be seen only when you have moderate to large amounts of pneumoperitoneum. Seen in 32%, and what is important is this is the second most common sign secondary to gas under the right dome of the diaphragm. And it represents what I said earlier, the luminal and the serosal surface of the bowel wall. And how do you see the inner surface? Because there's air trapped inside the lumen. So it shows the inner surface, and there's air trapped inside the parietal peritoneum or the peritoneal cavity, which gives rise to the opacification of the outside. So you have a visualization of both the outside and the inside. See these white arrows? So you can see both. You can see the outer and the inner. That is the double wall sign. Here also you can see the double wall sign. See both the signs. Now there is a variant of regular sign which occurs only the external surface of the bowel wall is seen. Now suppose if instead of the air inside the lumen, it is filled with fluid. So you'll not be able to see the inner wall. You'll only see the outer wall because of gas in the peritoneal cavity. So that would be a variant of the regular sign. It can also be mimicked by, suppose if two loops, see these two loops lying close approximated to each other, so gas in one loop and gas in one loop. So that gives rise to what is, so what you're actually seeing is what? You're seeing both the inner surfaces of both the loops. So it's not really the outer wall, you're just seeing the inner surface of both the loops. So that is a mimicking of the regular sign. And a pseudo-regular sign is when instead of fluid inside the abdominal inside the lumen, you have a radio-opaque content in the lumen. Like for example, if you have done a gastrographin study or barium study and then do an X-ray, there you'll be seeing what is known as a pseudo-regular sign. The second important sign is the cupola sign. It is an inverted cup-shaped lucency seen within the upper abdomen. Again, on a plane scagram of the abdomen, AP view in supine. See this radiolucency, the brown arrow? This is it. Now, where is it lying? This is across the midline. See, this is the midline, across the midline. Caudal to the heart. See, this is the heart, caudal to the heart. In the subxiphoid. So, the xiphoid is somewhere here. So, that is very characteristic. So, it is a transverse lucency extending across the midline just in the subcardiac area, and it is the subxiphoid region. Now it represents what? Where is this air lying? This air is actually lying in the anterior subphrenic space, which is located anterior to the stomach and the gastrohepatic ligament. The central tendon of the diaphragm forms the well-defined superior margin of cupola sign. So this is the superior margin formed by the central tendon, and gas collects below the central leaf, the most anterior portion of the diaphragmatic tendon, when the patient is in supine because the air tends to lies up. Potential mimickers of the cupola sign, which are false cupola signs, can occur if there is presence of air within the lesser sac, gas with the high transverse colon, gas within a horizontally oriented stomach, and pneumopericardium or pneumomediastinum. Now, that brings us to the diagnosis of secondary bacterial peritonitis, and apart from the sign that we just talked about, a CT scan or a contrast enhanced CT scan is a gold standard, especially when you're suspecting some kind of abdominal pathology or a bowel pathology. An ultrasound high resolution may help you, especially if you're trying to diagnose a primary pathology, like for example, the right hypochondrium. You may be able to diagnose a gallbladder pathology, you may be able to diagnose appendicular pathology. So it may help in certain regions, but remember, the gold standard is still the CT or a contrast enhanced CT. The treatment principles are simple, and just like in any hypovolemic shock, I'm not going to go to the details of that, but you just remember that the fluid electrolyte therapy is very important and has to be a monitored therapy, and monitored in the form that it has to be based on number of variables. Like for example, if you give me fluid, you have to look for the usual bedside parameter in the form of urine output, you have to look for the blood pressure of the patient, you have to look for the tachycardia of the patient, you have to look for the central venous pressure. Apart from the more sophisticated investigation, just let's talk about the routine investigation in a routine emergency ward. And then of course the electrolyte. And in all these patients, remember, always start fluid therapy with normal saline or renal lactate, which is to be preferred. That's not for this lecture to cover, but I think we have covered it earlier, or we may cover it in one of the future lectures on shock. But you can have a choice between normal saline or renal lactate. Renal lactate probably is better because normal saline can give rise to acidosis if given in larger amounts. And then of course, apart from the fact when you're sustaining the hemodynamics of the patient with the electrolyte and fluid, you should always decompress the bowel. You have to decompress the bowel. Why? Because the paralytic ileus or the bowel is distended. So go in for a nasogastric tube decompression. Catheterize the patient. You have to have a correct measurement of the urine output hourly. Then give this patient empirical antibiotics to start with until you have a culture and sensitivity report available with you. The patient is pain, give this patient analgesic. And then of course, depending on the cause, specific treatment has to be given to this patient. Right? The complications, abdominal complications in the form of paralytic ileus, there could be residual abscess inside the abdominal cavity, you could be having a portal pyemia, there could be liver abscess, there could be adhesive intestinal obstruction. Systemic You could be having a ARDS, that is acute respiratory deficiency syndrome. You can having a SIRS, you can having a septic shock, or you can have a multiple organ dysfunction syndrome or actual multiple organ failure. Right? Now coming to the most important complication, and that is intraperitoneal abscess. And what are intraperitoneal abscesses all about? Let's look at this figure, which is a very good figure. I found this out from the internet, and you can see the subphrenic spaces, you can see the paracolic, you can see the infracolic and the supracolic, and you can see the pelvic space. So these are the four important spaces we're talking about, four groups of spaces: the subphrenic, paracolic, infracolic, interloop, and the pelvic, right? In the infracolic, you got the right infracolic and the left infracolic, and the arrows show the normal traveling of infection, how it proceeds. So starting from here, pelvis, then it can ascend up or it can descend down depending on the site. So if you got supracolic, it can descend down. If you got infracolic, it can always ascend up, going up to the subphrenic space. Now, the spaces, if you look at the subphrenic, so the first group of spaces, you got the four spaces which are intraperitoneal and three extraperitoneal. Among the four intraperitoneal spaces, you got the right anterior, the left anterior, 1 and 2. You got the third, that is the left posterior, which is the lesser sac, and the fourth one not labeled out here, which is the Morrison's or the right posterior. The three extraperitoneal spaces are both the perinephric spaces and the bare area of the liver. Right? Now, if you look at the right subphrenic spaces, you got the anterior and you got the posterior, which is also known as the Morrison's. So if you look at the right anterior subphrenic space, you are talking about a space lying in between the diaphragm and the anterior abdominal wall. Posterior, you got the anterior surface of the liver, that is the liver. Superior, you got the anterior layer of the coronary ligament. See? And to the left, you've got the left leaf of the falciparum ligament, which can be seen on a there is a sagittal section, you can see a coronal section, or it can also be seen on a transverse section. The right side fossa communicates with the right posterior space, and inferiorly the fossa is open. But coming to the most important, that the right posterior, the subphrenic or the Morrison space, and here you got the inferior surface of the liver forming the anterior. The posterior is formed by the kidney, the adrenals, and the posterior layer, the coronary ligament, which forms the superiormost part, that the anterior layer of the coronary ligament. To the left, again the left leaf, the falciparum ligament. On the right side, the fossa communicates with the right anterior space, and inferiorly the fossa is open, right? The pouch is open. Okay, now coming to the left posterior subphrenic space. So the left anterior is not so important. We will be sticking to the left posterior subphrenic space. If you want to look at the boundaries of the left anterior subphrenic space, you can see two slides back. Now, the left posterior subphrenic space is the omental bursa, also known as the lesser sac, and this opens into the genital perineal cavity through the foramen vincelorum. See this figure, it's a very good figure. The foramen vincelorum opening to the right, and from where you enter into the omental bursa. So anteriorly you got what? The posterior wall of the stomach. You got the lesser omentum, and you got the gastrocolic omentum. See, this is the wall. The lesser omentum, and you got the posterior wall of the stomach, and you got the gastrocolic omentum. That's the gastrocolic omentum. And which part of the gastrocolic omentum? Layer number 1, layer number 2. Posteriorly, what do you have? Posteriorly, see, underlying what is this? The pancreas is there. So you got the visceral parietal peritoneum of the diaphragm. See, this is the posterior wall over the diaphragm. Anterior surface of the pancreas, that's the pancreas. The left kidney, that's the kidney. Adrenals and duodenum. See, all this is basically the part which is forming the posterior part. Above the peritoneum covering the diaphragm and the caudate lobe. That's the caudate lobe and that's the diaphragm. So that is above. Below, the fused third and fourth layers of great omentum. That is below. Right lateral, that below foramen. Left lateral, it has got the two ligaments, the gastrosplenic ligament and the splenopreal ligament. It has got a number of recesses, and the three important recesses that we're talking about are the hepatic recess, the splenic recess, and the omental recess. So these are the three important recesses: hepatic recess, splenic recess, and omental recess. These are the recesses of the omental bursa. The foramen vincelorum is important, and you have to know the boundary of foramen vincelorum, especially because if you want to go into a Pringles maneuver, you want to control the structures lying in the free edge of the lesser omentum, which form the anterior boundary of the foramen Winslow. You're talking about what? You're talking about to the right, you've got the bile duct. To the left, you've got towards the midline, you've got the hepatic artery, and behind you've got the portal vein. All three lying in the free edge of the lesser omentum. Posteriorly, the foramen Winslow, you've got the IVC, that's the inferior vena cava, and the right adrenal. Superiorly, you've got the caudate lobe, the liver. Inferiorly, you got the peritoneum covering the commencement of the duodenum. So see, this is the duodenum. Can you see the duodenum? So that is the inferior, covering the commencement of the duodenum and the hepatic artery out here. Right? Superiorly, you got the caudate lobe out here. So that forms the boundary of the epiploic foramen or foramen of Winslow. So if we look at subphrenic abscess, how does it manifest? Either there could be non-specific symptoms, there could be specific symptoms, or more specifically in a post-operative patient. Non-specific symptoms are non-specific, to say the least: mild fever, anorexia, non-specific abdominal pain, rarely tenderness. But more specifically, you can have a shoulder pain, you can have hiccups, you can have diarrhea with or without mucus, and you can have dysuria. Post-operative patient is a very important scenario where you should be suspecting subphrenic abscess, especially if in the post-operative period the recovery is either not adequate or there is sudden downturn in a recovering patient with fever, sweats, wasting, loss of appetite, epigastric fullness with pain, and specific symptoms as enumerated above. Like for example, a patient was recovering but now suddenly start developing hiccups or shoulder pain, then you start suspecting that this patient will be having a subphrenic abscess. And you should remember the aphorism, most important: pus somewhere, pus nowhere, pus would be found under the diaphragm. So if you're suspecting pus in the abdominal cavity, you're not able to localize it, look for pus under the diaphragm. Investigations for subphrenic abscess are important, and a plain skygram would be showing a basal collapse of the lung. It could be showing a minimal pleural effusion. It could be showing empyema thoracis. Ultrasound, or more importantly, a contrast enhanced CT scan would be diagnostic. In those rare instances where none of these work or none of them are able to diagnose a subphrenic abscess, still suspecting a subphrenic abscess, then what can help you is a radio-labeled white blood cell with either label it with indium 111 or label it with gallium 67 or label it with technetium 99M hexametazyme, hexametazyme. And when other methods fail, this is to be used, and it localized to those areas where you can see a high amount of radioisotope activity, and you can say, yes, this is the site where probably this patient is having an abscess. The treatment is always, remember one thing, the principle is it should be extraperitoneal drainage. Remember, we are talking about a localized abscess. Why do you want to make it generalized by going through the peritoneal cavity? So it should always be extraperitoneal. The principle is extraperitoneal treatment. How? Either guided extraperitoneal aspiration or a guided extraperitoneal tube drainage plus intermittent washout of that abscess cavity with local installation of antibiotic. In those instances where this doesn't help, you can go in for a extraperitoneal open drainage. Now, how do you approach extraperitoneal? An example of the right-sided. This is the right-sided. You look at the external posterior division and see you're going below the 12th rib. You enter here. This is the parietal peritoneum. I'm not breaching it. I'm directly entering into the abscess cavity. So the peritoneal cavity is lying here, has not been breached, and this can never become a generalized peritonitis. I'll drain this abscess, put in a tube, and I'm out. Similarly, more anteriorly, if it is more anteriorly, I can again go by the same route and I can do extraperitoneal drainage of a right anterior subphrenic abscess. So remember, a subphrenic abscess should preferably on the right side be drained extraperitoneal. Coming to the second most common site, and that's the pelvic abscess. And the common causes could be arising from areas or pathologies lying in the close vicinity of these areas. Like for example, complication of a peritonitis, secondary or primary, a ruptured appendix, or could be arising from the female genital tract, infection of the female genital tract. Clinically, how does it appear? Apart from the general symptoms of sepsis, there could be pelvic pain, that is suprapelvic pain. What is very characteristic is a mucus diarrhea. The patient is passing stool a number of times, but instead of having any fecal content in it, it is purely mucus and mucus only, which is a sine qua non of a pelvic abscess, right? Anterior rectal or posterior fornix bulge in a female, anterior rectal whether it's a male or female, and suprapelvic fullness could be found in a patient of pelvic abscess. The treatment is simple. Again, extraperitoneal drainage. So how can you drain it? The best is through the anterectal wall. See, this is the rectum. You're draining it through the anterectal wall. That is perhaps one of the best methods. But if it's a female, one of the better methods could be draining it through the posterior fornix. See, this is the posterior fornix. That the uterus, the vagina, and the posterior fornix. You're draining the posterior fornix. So either transrectal, transvaginal. In those instances where it has been walled off and you're not able to see the indentation, the anterior wall or the posterior fornix, then you have to go in for extraperitoneal drainage suprapubically. So suprapubic extraperitoneal drainage. In the very rare instance where along with the pelvic abscess, the patient has either cervical canal obstruction or acute canal obstruction, then you have to go in for a full-blown laparotomy. And in these patients, it becomes highly morbid. Why? Because remember, an abscess, the wall of the abscess is formed by the intestine, and the moment you try to separate the intestine, there's always chance of having an intraperitoneal fistula. So that is to be the least preferred option. Laparotomy should be the least preferred option of pelvic abscess. Most preferred should be transrectal, transvaginal, or a suprapubic drainage. Right? But coming to the worst form of localized peritoneal abscess, that is the interloop abscess, one which I would never like to handle, or I would never like myself to have an interloop abscess. Why? I'll just talk about it. Why? Because it is a very highly morbid and a highly mortal condition. But let's go from the causes. Post-peritonitis, malignancy, Crohn's, tubercular. The two very common causes, Crohn's, tubercular, and then of course post-peritonitis. What is the pathophysiology? Here, the abscess forming between the loops of the small intestine or between the small intestine and the large intestine along with the parietal peritoneum. So there is a very high chance of having an interloop adhesion, parieto-intestinal adhesion, and interloop or enterocutaneous fistulization. Clinically, early adhesive obstruction is the presenting feature. Non-specific symptomatology, again, pus anywhere inside peritoneal cavity. Diagnosis has to be by a CECT with an oral contrast, or you can do a white blood cell isotope analysis. Management, very, very difficult to manage. If you're fortunate enough, you can do a guided aspiration drainage. But more often than not, that doesn't suffice. So you have to go in for adhesiolysis, and the separation of the intestine is very, very difficult. Why? Because they're grade 4 adhesions, and the presence of fistulas is there, or the chance of having an adhegenic fistula is very, very high. So if you're able to do adhesiolysis, you should evacuate the pus, do a lavage, do a peritoneal drain, and treat the cause. But as I said earlier, very high morbidity and mortality, and one condition which I would never like my patient to be having, or I would be trying to treat a similar condition like interloop abscess. Coming to the complication of intraperitoneal abscesses, you can have sepsis, either acute or chronic. You have a very severe negative nitrogen balance. In fact, the patient goes into severe albuminemia, hypoalbuminemia, and you've got a cervical canal obstruction, acute canal obstruction, enterocutaneous fistula formation, spontaneous transumbilical. You have a spontaneous bursting of an abscess through the umbilicus, or you can have a fistulization, fecal content from the umbilicus, or it could be a postoperative scenario. Now coming to the last part of peritonitis, and that is the special forms of peritonitis. And among the special forms of peritonitis, the first one is the chylus. The pathophysiology is simple. Either you have a block at the cisterna chyli, or at the base of the mesentery, or the efferents going from the cisterna chyli, leading to what? A direct leakage of chyle through the lymphoperitoneal fistulas, abnormal or injured retroperitoneal lymphatics, or exudation of chyle through dilated megalymphatics, which could be congenital without a block of fistula. The causes could be either malignancy, which is the most common cause of chylous cystitis, because there the lymphatic system gets involved very early, gets blocked, and you have a back pressure effect and blowouts and fistulization. It could be fibrillary, it could be tubercular, post-operative, traumatic, congenital lymphatic disorders are all causes for chylous cystitis. The symptoms: it's a painless distension of the abdomen, and you can easily elicit features or signs of fluid in the abdomen. It is painless, and the patient has got ascites. Malnutrition would be there, and the patient may be dyspneic. Investigation: you do a parasynthesis, you aspirate what? Milky fluid. And if you look at the serum acetic albumin gradient, it's always less than 1.1 milligram %, and the acetic triglyceride level is 2 to 8 times that of plasma. It's a very high triglyceride level inside the acetic fluid. A contrast enhanced CT scan may be able to help you to diagnose the reason for it, but more often than not, a lymphangiography and lymphocytic scan is more informative. The treatment, because this patient is losing a lot of fat, you have to improve the nutrition. So what do? You increase the protein in the diet, reduce the rate of chyle formation, reduce the chyle inside the ascites. And how do you reduce the chyle formation? Stop long chain triglycerides and shift to medium chain triglycerides. Basically meaning use more of palm oil, coconut oil, which are basically absorbed by the enterocytes and transported through the vessels into the liver, as opposed to a long chain triglyceride, like for example fish and eggs, which are transported to the cisterna chyli by chylomicrons to the lymph. And here the lymphatic system is involved inside the abdominal cavity. So if you give more of long chain triglyceride, more of chyloside. So shift to medium chain triglycerides. Number two, high protein diet. Along with that, add diuretics. Add diuretics to the patient, correct the underlying disease, and they are debatable results with repeated paracentesis or peritoneovenous shunts. These are not methods which are in common usage. Coming to tubercular peritonitis, and the clinical forms are: number one, acute tubercular peritonitis. You can have a chronic tubercular peritonitis, and the chronic form, which is the more common form of tubercular peritonitis, could either be as a generalized ascites, or the ascites has been localized as an encysted ascites, or it could be a fibrous adhesive form, the worst case scenario that you can have, or you can have a purulent type, which mimics a secondary peritonitis or acute bacterial peritonitis. The pathophysiology is simple. From where does the infection reach the peritoneal cavity? Either from the tubercular lymph nodes, or it is a bloodborne infection, or from an infected female genital system, the tubercular self-meningitis, or it could be from ileocecal infection. The manifestation, I said earlier, acute tubercular peritonitis is an emergency presentation, and more often than not, if you're not careful enough, you don't have, you're not alert enough to make a correct diagnosis, you open up the abdomen and only then diagnose acute tubercular peritonitis. And how do you diagnose it? Because once you explore, you see instead of pus, you have straw-colored fluid, and you see nodules over the parietal and visceral peritoneum. And these nodules, which are found over the parietal peritoneum or visceral peritoneum, has to be differentiated from other conditions where we find similar nodules, like example acute pancreatitis, carcinomatosis peritonei, hydatidosis, and starch peritonitis. So this condition mimics acute bacterial peritonitis. That's why a sizable number of patients usually land up on the operation table, and once they opened up, then you diagnose, oh look, this is acute bacterial, this is not acute bacterial peritonitis, this is basically acute tubercular peritonitis. So that's why it says often diagnosed at exploration. But the most common is the chronic acidic form, which is a generalized form, where you have all features of tuberculosis, the form mild fever, weight loss, night sweats, abdominal pain. Generalized ascites can be elicited, and you can also find a transverse band. When you do a percussion, you can either palpate or you can percuss a transverse band across the abdomen, which is nothing but rolled up momentum, and first time appearing hernias at umbilical region or inguinal region in patients who never had them earlier. The investigations of the generalized acidic variety, a straw-colored exudative fluid, you do a paracentesis. AFB staining is positive only in 3%, so don't do it. Don't try to go in for a acid-fast staining in these patients. Why? Because the diagnostic rate is only 3% of patients. Culture, 35% positivity, slightly better, but if you do a centrifugation, take a centrifuge sample of the acidic fluid, the identification rate increases to 66 to 83%. And the better medium in which to culture it would be the Bactec medium, which gives a result in 14 days, as opposed to the LJ medium, which gives a result in 6 to 8 weeks, which is a long time to start treatment. Molecular methods are probably better. You can do a nucleic acid amplification test, you can do a PCR, or you can go in for a gamma, interferon gamma release assays. The other investigation, which has become the hallmark of acidic tubercular ascites, is the ADA, and that is more than 36 to 40 international units per liter. Very high sensitivity, very high specificity, 100%, 97%. A plain scagram may or may not help you. Complete blood count gives you slight pointer if there is an increase in the lymphocyte content of the differential. Diagnostic laparoscopy, multiple tubercles can be seen over the parietal peritoneum. You can take a biopsy, it becomes diagnostic. The treatment is simple. You can start this patient purely on conservative antitubercular therapy. Most of them do respond, If the patient has a very huge amount of acidic fluid, go in for aspiration. The encystic tubercular peritonitis is important. Why? Because the differential diagnosis, where it has to be differentiated from a mesenteric cyst, has to be differentiated from ovarian cyst. And the presentation is also different. These patients may present either with subacute intestinal obstruction or acute intestinal obstruction, and they usually have a lump in the abdomen, and that lump in abdomen is usually in the periumbilical region. Now, it has to be differentiated from mesenteric cyst, which shows the typical movement across the line of attachment of mesentery, or ovarian cyst, which can easily move into the pelvic cavity. The treatment of encystic tubercular peritonitis, the diagnosis can easily be made on a CT scan, and the treatment is simply by a guided percutaneous drainage can usually suffice in these patients. But coming to the most notorious and the worst morbid form of tubercular peritonitis, and that is plastic or fibrous. So here they have got fibrous adhesions of bands extending between the loops, whether small bowel or large bowel, and between the loop and the parietal peritoneum. So it presents with about pain, subacute obstruction, and acute intestinal obstruction. On examination, you'll find a doughy feel, you'll find a lump in the abdomen, may or may not be there, and you can find distension in this patient depending upon the degree of obstruction. Very, very difficult to treat. So if you're fortunate enough, the patient doesn't have a major problem of subacute or acute intestinal obstruction, a conservative anti-tubercular therapy with nutritional support suffices in the form of fluids or proteins or whatever is required depending upon the presentation of the patient. But if at all you want or you require a surgical intervention, by chance the patient has come to you with subacute or acute intestinal obstruction, then you have had it. Why? Because of very high morbidity and mortality. Opening the abdomen often is fraught with great danger, and the moment you try to open the peritoneum, and before you know it, you've gone into the intestinal lumen and the patient has got a fistula. So bad it is that is why there is one of the areas where the surgeon needs to tread very, very cautiously. So remember, if you've got a intestinal obstruction of tubercular type, you have to be very, very cautious. Try to treat this patient with conservative therapy. And obviously, your question would be, how would I know it preoperatively? A CT scan helps you. A CT scan helps you. It tells you about the degree of adhesions between the loops. It tells you about the adhesion between the loop and the parietal peritoneum. Coming to the rare form, that is purulent, where if you try to aspirate, you'll find whitish fluid, which is more like a caseous fluid. So this is nothing but really caseating mesenteric lymph node or a ruptured tubercular pyosalpinx, where the tubercular pus, which is the tubercular pus, has gone to the peritoneal cavity. It would clinically present as a pelvic abscess, it can present as an interloop abscess, it can present as a burst umbilical abscess through the umbilicus, or as umbilical sinus with pus coming out, or it can even present as an umbilico-enterocutaneous fistula, where instead of the pus coming through the umbilicus, now there is fecal content coming from the umbilicus. And these are usually in those patients where the rupture of the caseous material has also involved the wall of the intestine. The treatment, again, conservative or exploration, and subsequently, depending on the type of presentation, you have to proceed whatever the patient requires. Coming to familial Mediterranean periodic peritonitis, the synonyms: familial paroxysmal polyserositis, Riemann syndrome, and Wolff periodic disease. It is simply an autoinflammatory, primarily autosomal recessive genetic disorders, very rarely autosomal dominant, and presents with what? Fever and serosal inflammation. Serosal inflammation of what? The abdominal serosa, that is the peritoneum, the lung serosa, which is the pleura, and the joints with the synovial sheath of the joint. So these are the three important serosas to be involved, and that's why these patients would present with the typical presentation that we'll just talk about in the next slide. It's a genetic mutation in the Mediterranean fever gene, that is MEFV gene, which produces a protein known as pyrin, expressed mostly from the polymorphonuclear leukocytes. The disruption of this protein and its function leads to what? The cascading stimulation of the inflammatory pathway, starting from activation of interleukin 1 beta. So if there's a pathology or there's a pathological alteration in pyrin, it ultimately sets up the whole chain reaction of inflammatory pathway. Familial, it's a familial disease, runs in families. Epidemiology, why is it known as Mediterranean? Because it's found around the Mediterranean Sea, and the area or the geographical areas involved around the Mediterranean. It has to deal with the Arabs, the Armenians, and the Jewish population. The age, usually children, and that's why you'll have at least 90% of initial attacks occurring by the end of the teenage year, that is before 18 to 19 years. 90%. Uncommon in adults for the first time, exceptional after 40 years. Even if you're able to, or the patient comes to you for the first time, let's say in adulthood, if you take a proper history, you would get a history that yes, he had a first attack before he was 18 years of age. Females are more commonly involved as compared to the males. Clinically, as said earlier, the typical presentation, you may have a past history of appendectomy in that patient, but most commonly, among the more common periodic fever syndromes. And it has to be differentiated from other familial periodic fever syndrome, since the condition of familial Mediterranean has to be treated differently from other periodic fever. And the characteristic, as I said earlier, is fever and serosal inflammation. And I told you, abdominal. So what is characteristic about the serosal inflammation? Develops over 2 to 4 hours. The attack develops, or the pain develops over 2 to 4 hours, lasts for 1 to 4 days, and resolves spontaneously. Even if we don't treat this patient, it is spontaneously resolved. Interval between the attacks is very, very variable and can range from days to years. The Tel-Hashomer criteria, which is from Israel, is widely used for diagnosis of familial Mediterranean fever and periodic peritonitis. The sensitivity and specificity are more than 95 to 97%, which is really very, very good. And for the criteria, you have to have a typical attack consisting of fever of more than 38 degrees rectal fever, pain due to serosal inflammation, and remember what did I say? Abdomen, so the patient will be having abdominal pain, pleura, so the patient having chest pain, and joints, so the patient presents with polyarthralgia. So abdominal pain, chest pain, and polyarthralgia, along with fever, are hallmarks of Mediterranean periodic peritonitis. 3 or more recurrences of attack and duration of 12 to 72 hours. So these are the criteria that you're looking for in the Tel-Hashomer criteria. Treatment, the goal of treatment is control symptoms. We can't cure this disease, it's a genetic disorder, so you control the symptoms. And the best method of controlling it is called gene therapy, given orally or IV, and it suppresses the attack, except in 10 to 15%. It may prevent further attacks. It can also prevent systemic amyloidosis, which is the most notorious and more morbid complication of this disease, and it has to be continued as a lifelong therapy. The dose would depend upon the age of the patient. So if it's less than 5 years, then the dose is written down 0.03 to 0.07. You can read it up. As you go up the scale, more than 10 years adults, you go up to 1 milligram. You can even go up to 2 to 2.5 milligram, depending upon complicated disease, especially with amyloidosis. Interleukins have been used, which are interleukin 1 inhibitors have been used, because we just now specified that the pyrin abnormality leads to stimulation of interleukin 1. So if you inhibit interleukin 1, the systemic inflammatory response cascade does not get stimulated. Morbid complication is renal amyloidosis. There are a number of other treatment modalities, whole list of other treatment which have been tried out in familial, that is beyond the scope of this lecture. Biliary peritonitis, the causes could be any injury to the biliary system, obviously either iatrogenic or traumatic. So you have a CVD injury, which is a perioperative injury. You could have a leak in a DOCO, bilioenteric anastomosis. The T-tube that you put in after CVD explosion gets displaced. You have a biliary peritonitis. A duodenal stump leak after gastrectomy, you have biliary peritonitis. Post-traumatic, gallbladder perforation, all the instances, some of the instances where you can get biliary peritonitis. The presentation would depend upon how the biliary leak has occurred, whether it has been a gradual leak in a mild form, or it has been a sudden explosive leak of a huge amount of bile. So in those patients, you can have acute peritonitis and gradual leak in a mild presentation. But the morbidity and mortality is very, very high in any kind of biliary peritonitis, especially if you have a generalized biliary peritonitis. Early intervention and late intervention, they got both pros and cons. It is not for this lecture to delineate the exact method of dealing with biliary peritonitis. That is usually when we talk about the hepatobiliary injury and the CVD injury. We'll talk about that later, right? Then primary pneumococcal peritonitis, fortunately an uncommon entity, but was usually seen in the children, secondary to nephrotic syndrome or cirrhosis, we mentioned earlier. In the young patient, 3 to 9 years, usually teenage females, where it's ascending pelvic infection. In adults, if it's occurring for the first time, it's usually secondary to middle ear infection. The organism, as the name suggests, pneumococcal, rarely Haemophilus influenzae or Streptococcus or gram-negative bacteria. But the more common is pneumococcus or Haemophilus influenzae. The presentation, it is a sudden appearance, systemic fever, frequent vomitings, initial pain in the lower half of the abdomen with pelvic peritonitis features, like example again, remember the same thing, diarrhea, profuse diarrhea, burning micturition, and generalized rigidity and guarding. The differential diagnosis has to be from basal pneumonia. The diagnosis is easily made if you got a very, very high total leukocyte count, more than 30,000, abnormal paracentesis, odorless, sticky, opaque fluid. The treatment, conservative with support, antibiotics, that is penicillin. In resistant cases, use ceftriaxone and cofotexine. Surgical intervention may be required, which can be carried out either laparoscopically or by an open method. Other forms, which are very rare forms, starch peritonitis and peritoneal loose bodies, which we talk about when we talk about the peritoneal benign lesions. I think that finishes this lecture. Thank you for your time and patience. And for the recorded version of more and earlier lectures and instructional videos, you can always go to my YouTube Prime channel, the Rajiv Sinha JHS, and you find all the lectures uploaded